So we're welcoming Evie, who is a clinical nurse consultant with the post-lung transplant nursing team at the Alfred. She's worked in a variety of roles since starting at the Alfred, including transplant coordination, education and research, and her particular interest is in patient education and supporting lung transplant recipients build confidence and health independence post-transplant. So welcome to our peer group, and this will get recorded for those of you who can't make it back. So welcome also to those who are going to watch this back as a recording. So Craig and I are very glad to have you come along, and I know you're a really busy person, so we appreciate the time you've set aside to talk to us. So did you want to maybe just share a little bit more about what you do currently and maybe what got you into transplants, and then we can kind of go from there to whatever you would like to talk about
Yeah,
life after transplant.
very happy to, and very happy to be guided by whatever anyone wants to speak about through this session. I actually, it will age me, but I started at the Alfred back in '95,
Mhm.
and I was very much a cardiac nurse for many many years, and till I moved into the role of transplant, and that was a chance to sort of do both heart and lung, and have transitioned into the lung transplant unit. Oh gosh, I'm not even going to guess that one. That was probably back in about long time ago. And so I've done a few roles. As I said, I did the transplant coordinator role, which you all would be exposed to the coordinators in the middle of the night calling you at the time of your transplant. I stopped that back in 2006 and joined the lung transplant team, mainly in a research role initially, and I was involved with a lot of the clinical trials that the lung transplant team conduct, and met a lot of patients through that way. And as being part of Lungitude, you'd all know about the research that's conducted at the Alfred Hospital around changing practice for patients and how to improve their lung transplant outcomes over time. And I have recently, in the last 5 years, moved back into a more clinical facing role, which is what I'm doing now as a clinical nurse consultant in lung transplant. Um, it's a role that was new when it was first made, but it was really to bring a bit of nursing leadership into the department and really focus on the way nurses deliver care and how we can improve the patient journey and pathways, and how we can sort of add value to that area, which is what I've taken on and what I've really, really loved. My role initially was looking at the transition from inpatient to outpatient after transplant, because the feedback was it's quite daunting to leave hospital after transplant. And so we looked at how we could become, as outpatient nurses, more involved in the inpatient area, and spend some time with patients while they're an inpatient, help them build their confidence in us, and then be a familiar face when they hit the outpatient and they've left the ward, and kind of settle in a little bit smoother, we hoped, as we did it. And my role also involves engaging with patients in the outpatient appointments, as predominantly a nursing appointment we've started to do, which has been really beneficial to be able to spend some time with the patients and say, as a nurse, how can we help you? You've seen the doctor, you've done your medical management, but as a nurse, how can we help you, and what do you need from us, and how can we add some value to your, whether it be education, whether it be psychological, whether it be whatever it may be, and really have a nursing appointment that allows the patient to lead the conversation versus looking at the numbers and the boxes and things that we need to do. And that has really only started to kick off in the last couple of years. And we're now starting to add in the 12-month appointment too, to see how people are at 12 months from a nursing perspective as well. Um, and as Wendy would know me from, I actually do a lot of this education with the patients as well, and the Zoom education is one of them that we do, that Longitude is a big part of. Mm.
Yeah. Yeah. So you must have seen a lot of changes over the years as things have progressed, because I know originally the education was very minimal and then it all kind of kicked off as well. I'm mindful we've got patients from other centres here, so they obviously will have different arrangements or processes, but generally most patients will go through a post operative period, won't they, of education and of some sort. And Do you talk to the other centres at all, or is it each does sort of their own thing a bit?
We overlap a little bit when we get a chance to catch up, and we've just actually just had Leslie from Queensland down with us, which was really nice for a little while for a
Oh,
visit. And we were
okay.
all sharing information both way that way. So that was
Yep.
really great to hear what they do and for them to chat about what we do. But
Yep.
yeah, there definitely is a really, we've established kind of sort of a set program for that education after transplant,
Yep.
both from immediately on the ward and what's provided by the patients and to the patients from both the inpatient nurses as well as the pharmacists have a lot to do with it now with the medication education as well. And then the outpatient model that we do with the 10 weeks of education as well as face to face is required as well. I
Yep.
know the other centres have similar setups, but we probably a little bit different on our content and how we deliver it a little bit, I think, probably. Mm.
Yeah. So, what would be some of the things that as a very experienced nurse, transplant nurse, um, that you would love patients to know or to do differently? It's probably a long list there, but
Oh, the list could get long. No, look, I think with post transplant, the most important thing is that patients are really aware of themselves and their own how they feel. And I reinforce constantly early notification of new symptoms and things is really important. And I know as you get well and you return to life and that your health is not probably in the forefront, it is in that first sort of 6 months after transplant. It's times when things can slip through and people can become a little bit, I wouldn't say complacent because what we want people to return to life and do the things they love. But it can be, well, we'll put that off. I'll ring the nurses in a couple of days, or that's just a runny nose and I will tackle that. And then 5 days later, you're extremely unwell and we're trying to play catch up. So I think the thing that I like is that people should never feel that they can't reach out, that it's annoying to ring the Nurses Society feeling unwell. I want people to reach out and let us know that these are the symptoms they're having and enable us to sort of support them through whatever's going on. It may be a common cold, and that's what we all hope for, and you get well, but it can always be something else. So I think early notification is one of the things that I really am passionate about, people feeling confident to do and not feel that they're a burden by making those calls.
yeah. And when you run your sessions with the post-transplant patients, what are some of the other things you talk about?
So with the sessions, we cover a little bit about infection rejection,
Mm.
so what that looks like and why you're at risk of it. Covering the fact that life after transplant is a balance between managing the immune system and preventing infections, and that the medications are the key to that process. We talk about what sort of signs and symptoms to look for, and ways, particularly with infection, of avoiding infection. Um, Look, one of the ones we got quite passionate about recently is the gardening. It's become
Yeah.
on the forefront of everyone's mind, how to garden safely, with the risk of the fungus and things that love to live in potty mix and spores, and the importance of wearing masks and proper masks in those sort of activities. Um, I like to say there's not many things you can't do after transplant, but let's talk about how to do whatever it is as safe as possible. It's all
Mm.
about risk minimisation to do the things that you love.
Yeah.
Um, and then our biggest passion is the surveillance after transplant. It's all around the long term management of the complications caused by the medications. So it's the things of protecting the kidneys by staying hydrated and drinking that 1.5 to 2 litres of water a day. It's around sun smart is one. We know that skin cancers are really quite prevalent in lung transplant patients, and I'm sure for some of the Queensland people they're probably even more, a little bit more prevalent with the sun that you cop up that way. So the screening with getting your annual skin checks, wearing your slip slop slap every day, the sunscreen on, the wide brim hats, and really, if you're noticing new spots and things, that they get them looked at timely. So we really sort of skin cancer is one of the ones that we talk a lot about as well.
Yeah.
Yeah,
Oh, great. Well, I have more questions, but I'd love to open it up to everyone else
of
to
course.
query. So, has anyone got something they'd like to ask Evie? And if she doesn't know the answer, she knows the person who does. So,
I'll
so
find that
fund
one out
your
and get back
knowledge.
to you.
Yeah. Anyone going to reach out? Or
So
Robert?
Evie, yep, you just bowled with post transplant. You're not
Yes.
involved with the pre-transplant at all.
No, so the Alfred's set up slightly different to what they do in Queensland. So we have pre-transplant coordinators that have engagement with the patients while they're on the wait list and through assessment process. And then after transplant, we run a purely post-transplant nursing team where we follow them patients lifelong after transplant in our little group. Yeah, some of our transplant post-transplant nurses also coordinate, so the coordination can cross across both pre and post. But the pre-transplanters they manage the wait list and everyone through assessment and those kind of things, and then we take on after that. Yeah.
And who does the education for people who are having a heart and double lung transplant?
So post-transplant or both?
Or both, pre and post.
So pre would be done by the pre-transplant nursing team. They manage both the hearts and the lungs. So the pre team cover both heart and lungs.
Oh, rightio.
And then the post we break off into our organs. The heart lung transplant patients are predominantly managed by the lung transplant team. And so they would do the education with us, but they would also have some involvement with the cardiologist and the heart team as well.
Right, yeah. So they get education from the heart side of things as well.
Yeah.
And with your documentation and that education, do you have a sort of a section just specifically for heart and lung, or is it just in just the lung, like lung transplant education, and it's just covered in that?
Yeah, so we have each team has information booklets that are based on heart and or lung that we give the patients. So there's a life after transplant for hearts, and there's a life after transplant for lung booklet that we give the patients after transplant. And we both have separate medication booklets because obviously the medications are slightly different for hearts and lungs. So we have our own medication booklets that patients are given independently. And then we will follow that within the organ that they actually have done. And documentation in clinic notes, or just documentation that you give the patients?
I know more about documentation for staff.
Yeah, so we have a template within our clinic, within our hospital electronics. So we're electronic documentation down, and we don't have paper. And that template will be popped on, and it is a version that has both heart and lung in it. And that's where we document and communicate within the ward when they have the education and they get through. And then the Zoom education afterwards that we run, it is ran half with both and half without. So when it comes to life after transplant and pharmacy, it's run independently. So the lungs will do their sessions and the heart will do theirs. But when we come to do the dietitian sessions and the occupational therapy sessions and the physio sessions, they're run as combined sessions, and the presenters will deliver the nuances to each of those ones during the sessions, because a lot of it is similar, management. Yeah. So we separate them for the things that are completely different and bring them back in together for the things that overlap a lot.
Yeah. Right, yeah. Okay, thank you.
My pleasure.
Thanks, Robin. Anyone else like to ask a question?
I'll jump in.
Yeah, go, Craig. I was going to talk for the sake of it.
So post 10 weeks, obviously everyone does the clinic as they go through, and I think you said you do every 12 months. Is there a program now to follow up people on the nursing side more regularly?
Yeah, so we're just trying to roll that one out now. So we kind of do up to that 3-month point where we're quite deeply engaged. And so the clinic nurse has their role where they see them in clinic, and then we've set up the model where we have that nursing appointment at sort of 4 and 8 weeks after discharge to talk about how the process changes. And then after that, patients will then move to sort of monthly appointments. So we will catch them again at 12 months and have we've been doing it as a telehealth, so it's in addition to their normal clinic appointment at a different time, rather than having to come in and have so much on that one appointment time. And we are looking at how we can then evolve that out to be an annual sort of check-in from a nursing perspective, because obviously there's nurses in clinic every time you come to clinic, if you want to talk. But what we're really hoping to do is be a little bit more proactive, so that we're engaging with you and being present rather than you having to ask for us, if that kind of makes sense. So that sometimes can take the pressure off people going, I don't want to waste the nurse's time, or I don't want to do this. We're actively giving opportunities. And so we're hoping to move it out as an annual thing that's seen for the nurses. And then if there's other areas that patients think we can add value into being engaged, we're really keen to hear, because I think that's where the value of not necessarily some sort of nurse-led engagements and nurse-led clinics that we can sort of start to look at in the future. And what they
So is that just happening at the Prince Alfred, or is that the same as in South Australia as well? I mean,
we've just started at the Alfred, so South Australia hasn't yet, but I know South Australia has a lot. Laura has a lot to do with Mallory, one of our nurses, and has been looking at different models that we run here as well. I think actually she's coming to visit us soon too, so that'll be fun.
okay.
Oh, it sounds like you need a conference where you can all get together once a year.
we do have a conference
Bali,
coming up. Yeah, no, it's going to be in our conference this year. The Transplant Nurses Association conference is coming up in September, and it's in Sydney. So we'll get a day together there where we'll all share thoughts and ideas and come back all enthusiastic for what else we can do and learn from each other, which is what's really valuable.
Yeah, that's good. Would you mind just sharing the different types of nurses? Like, I'm not really that cluey on all of that, because obviously you're a nurse consultant, which sounds very fancy.
It does sound fancy.
Yeah. What are all the different levels of nursing, and who are the nurses that are involved, in the wards? Because I know they had extra specialties to be able to manage putting the pipes down the tubes and sucking things. And I remember someone saying at the time, "Oh yeah, they've had extra training." So how does all the nursing levels work?
Yeah. So at a hospital level, at an inpatient level, on the wards, you'll have a range of nurses, from the graduate nurses. They'll be on the wards that have just finished their nursing training. We have what we call registered nurses, who are right from a graduate year upwards. So you become a registered nurse and you're working just at that level. Then on the ward, they have clinical nurse specialists. So they're nurses that have spent a certain amount of time in a field. So it can be hearts, it can be lung, it can be other fields. So they've done a certain amount of time in their field, and then they've had to apply for that grade from the hospital and go through an interview and for that. And then you have your nurse ANUMs, or your nurse unit manager, assistant nurse unit managers, and they're the ones who are in charge of the shift normally each time.
Mm-hmm.
And you'll see them floating around giving support and helping out the nursing team there. And then you obviously have your nurse unit manager as well. And then many of you will have probably met, there's a CSND, which is a clinical support and development nurse that's on the ward as well. So she's big on education, and she supports all levels of nursing in both education and patient education, and also just the running and the governance of the ward as well.
Okay.
So they're the ones that are on the ward, but when you're in intensive care, the specialists who can suck things out the tubes, they're the nurses who've done the intensive care course. So they tend to be intensive care trained nurses that will do that. And down there in ICU, you might have those that are going through the course, those that are learning and about to start the course, and those who have got their postgraduate degree in intensive care nursing.
Yeah. Okay. So quite different areas to specialise in. Yeah.
They are indeed. And then when you get to our outpatient area, some of us have done intensive care, some of us have done a lot of ward and lungs. My role's the clinical nurse consultant, and we have a few more of them in the hearts as well. And then we have the clinical nurse specialists in other nurses that you'll see in clinic as well.
Yeah. Okay.
And they have varying experience depending on where their background is, whether they've come from the respiratory ward or whether they've come through ICU. But it's all very skilled and trained nurses down here.
I know, we love our nurses. I mean, they help you get through a transplant for sure. So, anyone else got any other questions for Evie? Jeff, you came off mute. Did you have something?
Yes, just on the skin cancers, is there any progress made on whether or not there's any breakthroughs on reducing the amount of skin cancers we're exposed to?
Yeah, look, I don't have any sort of researchy background on that to be able to tell you whether there's actually anything currently. A lot of it is a mixture of past exposure, as well as, because everyone after transplant's really great at doing all the things to prevent future exposure to the sun and sun damage, but a lot of it can be based on past exposure, and particularly when you get people who may have had outside jobs, whether it be builders, farmers and things that have had years of outside exposure, that risk kind of increases there. And the medications don't help it. Your immune system can't fight against these abnormal skin cells as fast because it's suppressed to stop it reacting to the lungs as well. So that's slowed down, as well as the medication making you more sensitive. It's a massive look. I think everyone would love an answer to that one for you, Jeff, because it is something that can cause a lot of trouble with people having little bits nicked off here and there to try and control it. So I wish I had an answer, but I don't have one for you that is any major great breakthrough that we've heard as yet, or I've heard as yet.
Okay, thank you.
Yeah.
No worries.
I know they're doing some more potential scanning with the Paula Fox Centre, because they've got some pretty cool equipment over there.
They are fancy over there.
Yeah, so I think there's was some discussions around how to link in the transplant patients with some of that on a more regular basis, which would be great. So that we can have the full scans properly done and keep track of things a bit better that way. So
and they are establishing sort of more complex skin cancers for immunosuppressed patients as clinics as well, that we can get people into a little bit more timely than sometimes we're used to. So that's
that'll be good.
But it would be nice to be able to prevent it rather than having to wait to find it, or to be able to pick it up earlier rather than finding it later. So it's getting engaged, and hopefully something comes out of there which will be really beneficial.
It'll be interesting to see as the years progress, because obviously before my generation, the younger people than me were the ones that were fully covered and had long sleeve tops and those proper hats at the backs and all of that. And so you hope that, their skin cancers from the past will be less.
Yes.
But, we'll wait and see. All right, who else had questions? Yeah, Jane?
Yes.
Yep.
So assuming you stay nice and stable, what would be the maximum sort of time frame the doctors would let you go between clinic appointments?
You're trying to escape us, Jane. Yes, look, really what we do is obviously once you hit that sort of 3-month point, you move out to monthly. And we normally would see you monthly till about 18 months. And this is all Alfred based, and I think it's similar across all units. After 18 months, things can move. They move out to kind of 2 monthly and even out to 3 monthly when things are going really well. There are the rare patients who are 10 plus years down the track that we might see 4 monthly, but that would be probably the cusp of it. And it's probably less that you're not stable, but more that we want to hit all those points. We want to have that lung function and those check your bloods and make sure everything's ticking along rightly, so that we're screening for all those things that be causing trouble and have that nice little trajectory going through and know it's all good to keep you out there. We have got better since COVID at the telehealth, because people want to travel and take off around Australia, as some of the people on this line do. And the advantage of that is that we can pre-plan for that and say, look, let's do this meeting. We're going to have a telehealth again in 3 months. We're going to get your bloods done in Queensland, and you're right without a lung function this time, but when you get back, we'll do you again in the next 3 months, and we'll do all those things. So telehealth does give you a little bit more freedom from us now that we didn't have pre-transplant. So that's one bonus that came out of COVID, was the telehealth. Yeah. But it does get there slowly. But then if you have a little hiccup, you come in a little bit more frequently, and then you might pop back out. So it doesn't mean just because you come more frequently for a few weeks as they tease something out, doesn't mean you're going to stay that frequently. You can move back out to that sort of 2 to 3 monthly again.
Right.
But it's you've got us forever, Jane.
I've seen you all.
It is lovely seeing everyone.
I'm just enjoying life so much.
It is, and that is the goal. That's what we want. It's like, what do you need to do? How do we help you do what you need to do, and how can we make it the easiest for you to achieve these things? That's what it's about.
Yeah, that's good.
It's not about being with us.
Yeah, it would be interesting actually we get a bit of that in the peer group where we compare what we're doing and other things that people have been able to put into their day, like Jane's off to the transplant games and things of that nature. So, and obviously Craig and Jeff travel a lot, and so there's there's lots of things that we've all been able to do. I know you mentioned the 12-month checkup. What's supposed to be checked up at 12 months? What are you looking at then?
So the 12-month initial 12-month and the ongoing ones. Your initial 12-month, they probably will always do an extra chest CT just as a standard routine one.
Can I just stop? Look, thank you
Oh.
for your time. I've got to go, unfortunately.
No problems,
No
Darren.
problem, Darren.
I'll look forward to the next Zoom meeting, but yeah, I've got to run. So thank you very much for your
My
time.
pleasure.
All right. Thanks. Bye.
Bye.
And yeah, so the 12-month one, we do a chest CT just as a sort of another sort of what we call it, surveillance one rather than an indicated CT, and they generally will get a full lung function done to look at all the volumes and things as well as just the spirometry. And then we run the extra blood tests like your cholesterol and so you do your fasting bloods at that 12-month one as well. From a nursing perspective, when we've been jumping in at that 12-month appointment, we've been doing a lot of reminders around the surveillance testing. So mammograms, pap smears, prostate bloods, skin checks, bowel screening in the male. And it's nothing outside the normal thing that's prescribed, but it's just a reminder to say, have you ticked these off? Have you got them on your mind? Have you made an appointment for them? So we kind of do get that little reminder about that reinforcement of those things as well. And each year the doctors just do a few more blood tests around your annual time, so around your anniversary. Not always spot on, but yeah, around that time. We don't do the ongoing CTs after that. They will only do them if they're clinically required. But they will probably get a chest X-ray done at that 12 months, each 12 months as it goes along, and generally a full lung function if they think it's deemed necessary. So just a few more things they try and catch. And it's a good time to say, have you been referred to endocrine? Have you been to osteoporosis? Do you need to see diabetes? Just a really time to look at where your referrals are and who you might need to be re-linked back in with. So it's that visit that can just enable us to just sort of catch a few more things, because some of them you're in and you're out and you're off you go and everything's great. So it's nice every about 12 months to just sort of reset and say, do we need to send a referral here? Have you got this ticked? How are you going with those things? It's a bit of a checkbox sort of visit. Yeah.
Yeah. Is it true that transplant patients still have the most touch points within the hospital? Someone mentioned that to me years ago.
They would have to.
Yeah. There's all the different
Yeah,
departments.
there's so many departments involved in all of you, whether it's from dermatology, if people are getting their skin checks done at the Alfred Dermatology, plastics if you've had anything removed, endocrine if you've got diabetes, osteoporosis if you've got bone health, DEXAs for scans, radiology for imaging, pathology. You would have to surely be one of the most touch points in this group, definitely.
Yeah. Well, there's a claim to fame we can all have.
Not the one you want.
Yeah.
But
No, not
it's good.
necessarily. No.
The longer we go, the more we accumulate, I think.
You are
Yeah,
very
yeah.
true. You do indeed, Jeff. You are in much more often at different time points the longer you get on. But that's, yeah.
Yeah. Do you have the numbers of officially, I'm not sure if you can share this because you're not telling us the specific patients, but who's the longest around at the moment in terms of years? Like I think we're into the 30 years, haven't we, for a couple?
We have. I think there's around about 30 or 32, I think, is still the longest.
Yeah.
And there's quite a few in the 20s and that now, which is lovely to see. And a lot of it's based on the research that's been done and the ability to manage the rejection a little bit better and fine-tuning that. A lot of it's just got to do with just managing health as a whole. And look, I think as transplant survival's getting better, it's becoming a process of working how to manage all the other organs that need support now, because there's other things cropping up, which is why you see so many different people. There's other things that crop up about healthcare. It's caring for sort of the aging transplant now. I'm not going to throw you all in under that category, but it is something that has come over that last, I guess it's a big change over the last 5 to 10 years is how to best, and we are transplanting older patients now than we used to, as well as we've got more confident in our selection criteria and who we can support. And so it is a changing sort of area in how to make sure we optimise all areas of care that patients need after transplant, not just the lungs.
Yeah, because we're still all getting old and getting other things. It's like, my friends in their 50s now, and they're all starting to have something that's gone wrong with them. I'm like, yeah, welcome to my world.
Yeah.
Finally, you got something. That sounds terrible,
Yeah.
but yeah, it's
No, it's
age
very
catches
true,
up with
Wendy. Yeah,
us. Yeah,
it
yeah.
is. Yeah, and that's the thing. Being able to be good at and recognise our limitations, and that we don't know all other processes as well. So there's other organs out there we don't know as well. So the endocrine team are who we throw you for your diabetes. They are the experts in that,
Yeah.
and utilising all the people who are experts in their field rather than thinking we can fix it all because we can't. Yeah.
Yeah. No, that sounds good. Any more questions for Evie before we wrap it up?
Well,
No?
just a quick one, you might help. There was a nurse named Coral who always did night shift about 3 nights a week back in 2014, and I saw her again when I had to go in about 2018 maybe, and she was still doing night shift, and she fosters children. So she's a very busy lady. Is she still around?
The name is very familiar to me, Jeff, but I've not worked on the ward in that time. So one of our other nurses, clinic nurses, might be aware because she works on the ward as well. She will know whether she's there or not. But I unfortunately don't know. But the name is very familiar to me, so I do know that she was there, but I can't tell you whether she still is.
Yeah.
She was very special.
Yeah, there's some lovely ones up there.
They all are.
Yeah.
I've just got a quick question about mammograms. So it doesn't matter what age you are, you have to have a mammogram post?
We normally start it according to the normal guidelines. So I think it's 50 that we encourage people to start having mammograms annually from. And then after that, and just through breast screen, we don't sort of do it any other way, just through the regular screening processes. Same with the bowel screening, just through the regular national bowel screening process. So just through breast care, the way people would normally be allowed to do it.
Yeah.
Because if you don't have any indications, no family history in that, you have to pay for it.
Yes, I think breast screen, you're allowed to do it second yearly from 50, I believe. I would have to go and check that again, but I believe you can start it earlier.
Yeah, that's right. Yeah, and then if you've got family history, so we've had my mum and 3 sisters all died from it, and so I go to the breast guys at the Alfred and have yearly tests because of the high risk of the family history. But otherwise, they said it's usually GS. And sometimes I'll do it with a contrast in, which picks up it better. But this year they said, no, you can wait a year for that. So they're only doing that every 2 years unless there's something that gets picked up on the mammogram. So it is really dependent. I think, and breast screen's a bit like that too. They'll advise depending on all your history, and some cultures have more lean more towards breast cancer as well, so they'll also pick up on that. And then it varies. So I've been getting seen since I was about 40 because of all the complications. But you do have to push for it a little bit. But there's some very good people at the Alfred who do that side of things. Yeah.
Yeah, and breast screen is the one that's funded, so it will not cost to go for that. But it is, I think it's recommended every 2 years at least for women over 50.
Yeah, and free from 50. Yeah. Cool. Anything else? We've done pretty well for timing. We've got 3 minutes left.
That's all right. We've done well.
Yeah.
No, it's been a pleasure. Thank you for having me on to talk, and
Yeah.
I'm happy to answer any questions that people may well have.
Yep.
And that's what we're here for.
Yeah, no, that's great. So thanks, Evie, and we are very glad that you're been part of the team for so long and can share all your expertise with others as they, come to develop their own resources and things. And we're very happy to have had you on. So thank you.
No, my pleasure. Thank you.
Okay. We'll wrap it up there.
Thanks, Yvonne. Nice to see you again.
Lovely to see you all. See you soon. Enjoy